they lose ability to move their arms, legs, feel anything, shoulders down, and don't really have great prognosis afterwards, unfortunately. Data set that we have involves over 1,000 patients that have spinal cord injury that were enrolled acutely. And AI is, it's going to be involved in all fields of medicine.
I love the idea of AI in your brain.
Different institutions don't share resources. It's very hard to find a way to collaborate with institutions without having the risk of exposing your data or leaking the data. With the use of Super, I think that those collaborations could become possible. It's saving ownership. So when you spend, $10 million on in 10 years obtaining data set, you'll be very careful how you disseminate that data. And using technology of this sort, you're guaranteed that you do not expose your data. Your data is not only not misused, they will share without really sharing their data again. There is no limit how much you could collaborate between different universities.
Hi, and welcome to Confidentially Yours. And I am delighted to welcome today to this episode, George Jimsheleishvili. Have I got that right, George?
You did, great.
Excellent. So George is an associate researcher at the University of Miami, which is one of America's top research universities. It's part of the prestigious AAU, and also particularly known for the Sylvester Comprehensive Cancer Center, I believe. Is that right?
That's correct.
Yep. Cool. And so, George, tell me first a bit about you. Where have you come from? Have you ended up here? What do you do at Miami?
Sure. So thank you for having me. I'm George Jimsheleishvili. I'm a neuroscientist. I joined Miami Project to cure paralysis back in 2008 when I took a year off in my med school. I did a science year. And then I joined it later full-time in 2015, and we've been trying to move forward to the science related to paralysis, nerve injury, brain injury, and other conditions lately, including...
So you're a neuroscientist?
Correct.
Specifically. Okay, right. And that sounds like a kind of a big thing to be trying to cure, right? Paralysis. Is that all types of paralysis, or are you specializing in any particular types that we should hear about?
Yeah, we mainly try to tackle traumatic injuries that lead to paralysis. It's quite a big challenge because the nature is not really on our side, but we try to learn it, understand what are the ways to approach it, and hopefully try to cure it one day.
And what sort of injuries can cause that type of paralysis, and what can that lead to? Is it full body paralysis you're looking at, or particular types? Just tell us a bit more.
Sure. So if I could hold a huge sign and walk with it or put it in few areas, especially in the waterfront locations, people get injured mainly. Well, the most common injury type is the traumatic spinal cord injury resulting from motor vehicle accidents. But a lot of youngsters go party, have fun, dive headfirst, and they break their neck. And just this weekend, the same thing happened. They lose ability to move their arms, legs, feel anything, shoulders down, and don't really have great prognosis afterwards, unfortunately. So that's what we're trying to work with mainly.
Sure. Okay. So it sounds like it's very much not just theoretical research that you're doing. It's where do you sit in the sort of just looking at things on a whiteboard to touching patients and meeting them? Where do you sit on that, and where does your group sit? Is there a variety of people?
Yes, definitely. So Miami Project is pretty well known worldwide as one of the largest spinal cord injury centers. We're involved in all of the aspects of developing treatment, starting from basic science. We have huge team, hundreds of people working day and night, And then we are also involved, and I'm mostly involved in clinical trials when we try to bring that advancement in science towards the bedside and particularly to the patients. So we have done variety of clinical trials involving Schwann cell transplants, stem cell transplants. We're involved now with electrical stimulation, chip implantations with Neuralink. We run multi-center
Yeah,
hypothermia
I've heard of
trials and so
Neuralink.
on.
Tell me a bit about Neuralink, because I think that's been in the news a bit. So I'd love to hear a bit
Yes,
more about
it's
that,
been in the
if
news.
that's okay. Sorry.
Yeah, no, of course, it's been in the news more than anything else, and because it is really exciting what new technology can do. And although we've in Miami project been more targeting neuroregeneration, the current technology is trying to circumvent the spinal cord injury and also the ALS, the amyotrophic lateral sclerosis, by trying to connect the brain directly with the technology without even needing to have the spinal cord involved and working. So yeah, we're one of the sites, and a lot of information is public now. So that's what I can also briefly mention, that we have implanted chips and they've been doing well.
That's really interesting. And so tell me, I mean, ALS I've heard of. There's a few sort of high profile names. That is that a specific type of disorder you're trying to treat, or is it a broad spectrum of things? Tell me a little bit more
Yeah,
about
it's
that.
the target being ALS is not necessarily because it's ALS, but because it leads to paralysis and an inability to move the arms and legs. And both conditions are devastating. And what happens, if I can just briefly describe, is that in these are very, very two different conditions: spinal cord injury and ALS. Spinal cord injury, people live normal life, enjoy their life, and in a brief millisecond, something happens, motor vehicle accident because some not enough attention or intoxication or other reasons. Or again, people will jump in a pool or in the ocean. In Miami, it's not deep anywhere, and people don't see that. They'll do one
Sure.
little mistake, and then it keeps them paralyzed for life. Many, if not everyone. And ALS is even more devastating because the big difference is that people with spinal cord injury, in most cases, will live a full life, even though they won't have ability to walk or sometimes move their arms. They'll be relatively healthy. I mean, they'll be healthy otherwise, and they might have full life and have job and families and enjoy their life. While ALS is more devastating because people slowly lose their ability to move all of their muscles.
It's degenerative. Okay. Right.
Right,
Yeah.
right. And it ends up being not being able to move the muscles of respiration. So people aren't capable to
Sure.
breathe on their own. So it's even more tragic, if I could say.
Sure. Okay. Sorry. Well, let's try and move on to some maybe more sort of more upbeat topics. And I mean, we're here to talk about AI generally, but AI in healthcare is a big set of topics, right? It's not just your work. There's, the FDA has been looking to encourage development of a variety of medical devices. Including some which incorporate AI. There's really quite a rapid evolution, as I understand it, of AI in healthcare as everywhere else, I guess, these days, and obviously concerns that we're not jeopardizing the safety of the patients, or I guess, in fact, the researchers as well. But from your point of view, what are a few of the things that you've seen outside your area of healthcare that you might think were interesting to people?
So what I think in our fields is an issue is that we've been trying a lot, and we should keep trying more and harder to cure spinal cord injury and other conditions. But the challenge is huge. And even though we should keep going, I think we need to start implementing technology on a higher scale. And AI is, it's going to be involved in all fields of medicine and in general in our lives, whether we like it or not. The issue is that it needs to be highly monitored and regulated. But technology is most likely the future. It's the answer to the problems that we're not otherwise capable of solving.
So things like personalized treatment, I guess, based on AI capabilities, smart implants, we've already talked about a little bit. Will there be different types of treatment based on diagnoses that are provided differently by AI? How do you see AI helping in that side of the world?
Oh, AI, not just that. AI can and should and will be involved to do most of our jobs, including mine. It can help with, it can help.
You are, just to check, you aren't AI, right? George,
I'm
you do,
not
you are.
AI. Yeah,
Okay, fine.
I think so. Yeah, I'm pretty sure. No, AI can help. So with lots of things, and to bring a couple challenges first to mention. What's the biggest issue in research? Well, many cases it boils down to resources, the finances, the manpower, the time, the effort we all need to put in. What AI can do is it can minimize the time and effort you need to put to obtain particular set of data or go through analysis of the data. You can use it in radiology. You can use it to save physicians time. The applications are variable. I wouldn't be able to list even 10% of them.
Yeah, I saw a thing recently, I think, about how AI is being used to look at radiographic scans of lungs to look for things like bronchial issues, which might suggest lung cancer, for instance. Is that the sort of thing you're talking about?
Of course, and we recently have been working on a publication that I'll mention briefly later again if you'd like. But we used the study where AI was used to read spectroscopy data, so protein values in different parts of the brain to determine whether particular part of the brain is more susceptible to regrowing tumor after it was removed. And AI can be used as diagnostic tool, which would do it incredibly faster compared to the human, which is very important when we talk about the cancer and its recurrence because it's very time sensitive. Because if you wait too long, it might be too late to try and attempt to help it.
Okay, so I love the idea of AI in your brain. It kind of feels like you're combining the two in different ways. And I understand that there's one of the concerns and one of the ways that AI is being used as well is to try and improve digital services for people who maybe don't have as much access to medical opinion or medical experts as before, because I guess chatbots and things like that can lead you through a pathway in ways that require fewer experts in the front line, which means they can then presumably concentrate on the more complex tasks that AI maybe isn't ready to do yet or we can't scale yet. Is that a fair way of looking at it?
Yes, well, I have a little bit of concern with that. So I think that AI will maybe one day be ready, but I don't think it's ready to substitute or take on trying to interact with the patients on its own. Because even though might have a lot of information, there are many points. One of them is trust. There's ethical points and so on. But what AI can and is already in most places utilized as is an assistant tool to healthcare providers and also, of course, in research. And we are using it in research already. We'll scale it more, and there are some challenges. But I think with the advancement of technologies, it's just inevitable that lots of reasons to use it even more.
Excellent. That's a really good sort of background to various parts of healthcare and where AI fits. Maybe we could just delve in specifically to what you're doing and what some of the problems you're addressing. I don't know, some of the problems you're addressing and some of the challenges that you've had as you've been doing that, and then maybe talk about how we use AI to do that. But give us an intro, a bit more specific information into what you're doing and the challenges you've faced trying to do that.
So what I'm involved in mainly is clinical trials revolving around spinal cord injury, paralysis, when
Yeah.
people get a traumatic injury that dramatically changes their life. And we try to do informational studies. We try to address the injury very early on, and also we try to sometimes give it time to see and hope that people will recover at some point. And we try also not to intervene with that time, and then implement different technologies or different strategies to help them recover potentially. One of the main studies that we run is a multi-center hypothermia study where we cool people down, hoping that the cooling will minimize their secondary injury. And the idea is, and this is how I explain it to our research patients, that if you injure your pinky, what do? You apply ice to it, right? So we try to sort of do the same to
Sure.
the patient's spinal cord by cooling their entire body few degrees. We don't freeze them, so as some people
Good.
think, or anything like that. Again, we've tried neurorestorative strategies, and we have transplant. We're most well known for transplantation of Schwann cells inside the spinal cord. We have also have been and are still currently transplanting Schwann cells in peripheral nerve injuries when people will injure major nerve and they lose the function of particular limb. We reconstruct the nerve, and on top of it, we augment Schwann cells. So basically, we add their own cells delivered from their own nerve that we grow here in the Stem Cell Institute at the University of Miami. And obviously, we're running many other studies where we try to learn what we should do next with the spinal cord.
And I'm not an expert, but this sounds like a huge amount of data, right? I'm really not an expert. You asked me the other day, to explain as best I could about spinal cord injuries, and I was very bad at it. But it sounds like there's just enormous amounts of data here, right?
That's completely true, and it's one of our largest challenges to keep obtaining the data. You need manpower, you need time. And that's the part where technology can definitely be assistive.
And so I guess that all of that data belongs to people as well, right?
True.
How does that data? Yeah.
Yeah, and we're very, very careful with that. Whenever you're running clinical trial in medical field, you need authorization from regulatory organs. Sometimes it will involve FDA. Sometimes you'll have a sponsor, such as Department of Defense. All studies need to be approved by institutional review boards and sometimes Office of Research Administration. And in many cases, depending of a study, you need permission from individual patients to use their data or their tissue or whatever intervention you'll be conducting.
And so that data, I mean, it's not as if they give it to you and you can do whatever you want with it, or specifically not share it with other people, right? Presumably you're combining it in ways where you have to be very careful that it doesn't leak. There's, I'm aware, lots of regulation, not to mention ethical standards that you want to be upholding yourself as a scientist and as a healthcare professional, of course, as well. And so I understand that one of the tools you're using is the Super Protocol platform, right, to isolate this data and in fact the models you're using, I guess, from anyone who might be trying to get it, so that you can absolutely be assured that there's no way that data can leak or it can be extracted. Is that part of how you're using the platform? Is that how you think of it?
Yeah, so we haven't been using it for our current trials, but we have been conducting a test where we consider using it as a platform that will allow us not necessarily to hold our data on, but to allow us to collaborate with different institutions. So
that's interesting. Carry on.
When it comes to collecting data, again, the resources, finances are usually one of the main challenges, and every institution has ability to some extent to conduct particular research. But in science, larger samples you get more credible and more useful that data is. The issue is that different institutions don't share resources. So when one institution secures a grant, then that funding will be used only in that institution, and it will generate the data for particular that study.
Which restricts the data sets they can act on, and therefore the results they can get, right?
Definitely. And that data will most likely never leave that institution and will not be utilized by other institutions. So when I heard about a super protocol and the technology that it provides, the first thing came to my mind was we can work together, all the different institutions, so that all of us work day and night, and we're very careful because we spend so much time. We spend our health and time and energy in trying to, yes, not just collect the data and keep it, but to make sure that this data is interpreted correctly. And we're always trying to, and we're welcoming collaborations, but it's very hard to find a way to collaborate with institutions without having a risk of exposing your data or leaking the data, and that data now can be misinterpreted, or you basically lose control of it. So with the use of super, I think that those collaborations could become possible.
Excellent. Maybe I should just briefly give an intro to Super Protocol, because not everyone will necessarily know about it. So Super Protocol uses confidential computing, which is hardware-based, what they call trusted execution environments, to isolate your AI model or whatever application you're doing and all its data from all of the rest of the world, not to mention that machine, and allows you to do your computing, in this case AI work, with data which can be taken from a variety of different places, and you can prove cryptographically that no one can look at it, that George can't look at it, his administrators can't look at it, the IT people can't look at it. So you're providing those technical assurances to those other owners of the data that their data is safe, whilst also being sure that it's the results that you're creating aren't going to leak to places they shouldn't be doing either as well, right? And Super Protocol aims to make it so that you don't need to be a hands-on, lots of ones and zeros techie in order to be able to use this. And I know that it's still, it's an ongoing journey, and the technology is maturing. For you, George, what was when you first looked at Super Protocol, how did you find it, and how have you found getting on, and what does it provide you of those capabilities that you're looking for?
Yeah, when I first found out about it, I had great feelings and also concerns. And my great feelings were that imagine what this can lead to and how much it can enable us to unite as different scientific groups. And my concerns were how much we can investigate and audit and make sure that it's safe and there will be no data leakage and so on. So learning into it, I think, is the most important part. And I think scientific community, should address it same way it addresses everything else, with skepticism, but with interest to investigate and see on their own how it works, and make a decision on their own if they would like to use it or not. And just to add something here, I think that whether you are suspicious or not of something having an issue, once you test it, once you know that it can help and it can increase the efficiency in the work you're conducting, that's meant to help others, I think there comes an ethical factor of should you use it or not? And I think it becomes a little bit unethical if you know that you can use some technology that can create benefit for our patients and choose not to utilize it. I don't think that's a great choice. And again, whether you trust it or not, if you don't trust it, I think you should investigate it. But there will be a point when technology use will be inevitable, and it will increase the quality of the science overall.
I really like the application of the scientific method to the tools as well, because we don't always think of it in that way. But I think it's really, really important in this sort of case. And I'm as a cybersecurity professional, and approaching things with skepticism is absolutely the approach I take. Although I come from a very different field to you, and I too, when I first came across this technology, it sounds too good to be true, right? What can we do to get the assurances from the experts in the appropriate fields? And as you say, if it's there to be used and it provides benefit, it becomes not a why would you use it, but why would you not use it question. And I've not heard it framed as an ethical question before. And I like that. I find that really refreshing, actually.
Yeah, because if there is intervention that I personally am not fond of, and I don't think it's a great thing, but if I see evidence that it's useful, is it up to me to decide not to use it? Right. So I don't think so. I think we
it,
have
it,
to.
it, it echoes stories from sort of last century. Well, I presume everyone's listening to this in the 21st century. So from the 20th century, of the discovery and the isolation of insulin and how they realized the difference it could make. And even before they'd necessarily done all of the work they wanted to, they felt that they had to use it because ethically the choice not to use it was unacceptable. In this case, we can actually do all of the due diligence we need to first, but that ethical imperative to use things that we've discovered or technologies that we've come across is a really interesting perspective. I thank you, because I really hadn't thought of it like that before. So you're not a computer scientist.
Not at all.
You're not a
Definitely not.
cybersecurity technology, and I guess that most of your colleagues and the people that we want to be embracing these technologies are also not. I mean, there will be some, and hello to all of you. But what would you expect? What would you hope, if not now, in the coming months and years, should be the experience? You're an early adopter, so you've probably had it harder than they would like. But how would you like it? How would you like people to be able to use these technologies, and what should their experience be as they approach it? Again, thinking of it as a non-techie with a non-techie hat on. I love typing lots of commands and stuff, but I guess that for most people that's really not their preference.
So I have. You're correct. I'm not not an expert in this field, definitely. And I have a hope and I have a thought, and I'll start with the hope. What I hope is that the experts in this field, which we actually do have, University of Miami has great technical experts who understand this field very well. I hope that they look into it and they determine whether we should use it or not. Me included, and my colleagues, they get advised, and I believe that once they would investigate, I believe that they would advise us to utilize this technology. And what I think is that since 1,000 years ago, when we traveled via horse, and then one day there was a flying tube with wings invented, there's no going back to the horse, right? So there's no way you're going to travel any other way. Well, you can train and boat, I guess, but you understand what I mean. The same thing will happen to the science, and with the use of technology will step up, the new standards will get adopted, and it will be very hard to go to outdated ways of conducting science.
And in terms of ease of use, what sort of expertise or what types of how you access the technology would you expect or would you hope to see as we move forward? Because command lines and ones and zeros are not for everybody, right?
I agree. It's definitely for me. It's not easy to use technology that needs command lines and knowledge of technology. But I think large institutions have capacities to utilize technology that has these requirements. But as time goes, I think the ease of use should become better, and the user interfaces and the accessibility of these programs, I think, will also improve.
Thank you. So I'd like to go back to a thing we talked about a little earlier on, actually, which was this question of collaboration, because it's clearly a really important one. And you talked about how you have large organizations or sometimes smaller organizations who have their own data pools, their own data sets. I don't know how you would refer. What would you call it? A data set? Patient data set? What's the...
Yeah,
okay.
data sets.
Yeah. Okay. And working out ways to allow them to collaborate whilst being sure that that data isn't going to be exfiltrated or leaked or misused is clearly important. First of all, have I got that right?
Of course, definitely. And so here at the Miami Project, we are part of a large group of scientists that investigates spinal cord injuries called North American Clinical Trial Network. There are big universities involved, and the data set that we have involves over 1,000 patients that have spinal cord injury that were enrolled acutely, which is harder to enroll, we would argue, because
Sure.
of the time frame that is given. And no one in the world has larger data, as we know, except of a group in Europe that has even larger data. And when I first heard about this technology, the first thing came to my mind was we should analyze both of these data together with a simple algorithm that looks at, let's say, recovery rates and see if there are any differences in United States versus or North America, because we
Yeah.
work together with Canada uh, compared to Europe. And I don't know, of course, if the leaders of either our team or European team would agree to use this technology. I hope they would, but I think we would find interesting results. Sorry, also to add, there is no limit how much you could collaborate um, between different universities. And in general, most universities, yes, they run different studies, but they do collaborate. There are collaborations. We work together with many universities. We have one studies that are run by multi sites, but you can it's hard to collaborate on studies that have been finished, that have already obtained the data and own that data. It's hard to convince other universities to provide you with that data. And this way you could look or analyze at the data without looking at the data. So that is
Yeah.
I
So
think the
yeah, because
great
the humans
point.
don't need to look at the data because you've got these AI models and you can show that the data isn't going to be misused. You can put it all in one place and do it like that. So yeah, in ways. So presumably this is a huge time saving, if nothing else. That going through all the legal hoops and trying to get the agreements. If we can get everyone to agree that this is a mechanism that we can use to do this in a way that's safe and meets all the relevant regulations, the amount of time and money spent actually agreeing it could be reduced significantly, right?
Not only time, it's saving ownership. So when you spend, I don't know, $10 million on in 10 years obtaining data set, you'll be very careful how you disseminate that data. And
Sure.
using technology of this sort, you're guaranteed that you do not expose your data. Your data is not only not misused, but it's not accessed by anyone, including owners of this company. So that provides sense of security that you can work with other institutions who have valuable data. You can combine this data. You can do machine learning on this data and various other things while everyone maintains their own ownership of the data. That's going to be fantastic next step in the scientific community.
That word ownership's a really interesting one because we've been talking about institutions, but for some data and in some jurisdictions, you can think of that data as actually owned by patients or by their families, right?
Not necessarily. No, when we enroll patients in our study, we actually enroll them in informed consent process, which is a document that they sign. But not only, we explain that their involvement is scientific. They're contributing to scientific field, and we inform them that their data is not going to be shared with them,
Is
and it
there
will be
is there a
shared in
mechanism?
publications.
Is there a possibility in the future that individual patients could decide to enroll their data or not, given that these safeguards are in place? Do you think that's a likely possibility or not really?
Definitely, but we're talking about different things. So
Okay.
in interventional studies, you would need scientists to be involved and to be proactive and seeking patients with their inclusion exclusion criteria. There,
Yeah.
it's more comprehensive. But with that kind of technology, definitely there could be avenues where patients could self-enroll in studies and decide what kind of data they would share without really sharing their data again, right?
Yeah, it's fascinating. I have to say, the looking at because there's this big thing about sovereign data, and we tend to think about about your bank account and things like that, but there's no reason that some of that might not be healthcare data as well, and patient data as well. Okay, that's really interesting. You talked a little bit about Europe. I guess not just Europe, right? Once you start thinking about this, there's all over the world. There's hospitals with researchers and information that you can share. As Are there issues around sort of data formats and things like that, or are they minor problems in terms of compared to this bigger problem of security?
Yeah, I think the biggest challenge is the time and effort it takes to run and conduct these clinical trials. As far as security, I'm not in position, and neither am asking anyone to trust security of these applications. When my suggestion is to investigate, to look into it, to see a
Yeah.
potential whether this should be used or not. And when the experts, our colleague experts who specialize in technical field, determine whether we should apply this technology on larger scale or not, I think after that we should start utilizing it worldwide.
Could you explain to me, because I really don't know the field at all, the data that you're collecting at the moment, how is it gathered? Is it from scans? Is it from physicians typing in data from things they've looked at, or from blood tests, or from machines? Or we talked about spectroscopy, for instance. I can't even say it. Where is this data coming from at the moment?
So different studies have different ways to obtain the data. Some of the data is obtained through patients' medical records. Some of the data is generated in live. For example, when we examine the patients, that generates the source data that we later use for analysis. And large scale validators are usually obtained with machine learning tools and other technological utilities. But yeah, there are different ways to obtain the data, and that is definitely an avenue where AI could help. But not only there, the analysis of the data, finding new important variables in the data. What would be a variable that has an effect or has importance in prediction whether this person will recover or not? That's another avenue where AI will.
So there might be a factor which you hadn't realized was important, which comes out because the AI has just run all of the possibilities pretty much and said, well, actually, there's a correlation here that we hadn't seen before, and therefore it's worth looking at in the way that you're looking at temperature. Maybe there's something to do with pH, or I don't know. I have no idea about these sort of things, but yeah.
Exactly. You're
Okay.
correct. So, not it might not be just one variable, but it
Sure,
could
it could be
be
the confluence of variables. Okay,
couple
yeah,
plus
yeah.
couple or more variables, which is hard to do on a for a human brain, but probably very easy for a machine to.
Excellent. And so one of the things that you talked about is sort of getting some measurements, but we're moving to a world where we've got more health sensors. People have watches, or they might have implanted insulin pumps, or defibrillators so there's a whole bunch of things going on here, right? And I guess that collecting that data, and even in the longer term using that in real-time data analysis in ways which, again, we're protecting that data, which is very sensitive, particularly for people who are living day to day and could be affected by by people misusing that data. That's a future that we can look forward to as well, is it?
Definitely. One important thing we have to note that any data that is collected from humans needs to be collected with permission, either of the humans or the institutional review boards.
Yeah.
There are some details I might don't need to go to in very detail, but mostly the prospective data needs to be obtained with permission of patients, and
What does
retrospective data with.
prospective data mean? That's a term that, well, I don't know, and I suspect
So
other folks may not know
prospective
either.
and retrospective are the data that you collect either in future from the day on you decide to collect the
Okay,
data, or collect something that happened in the past. So the
thank you.
past data doesn't generally need going to the patients and asking them for permission, but you need permission of institutions. And in prospective, in most cases, you'll need permission from the patients. Now, how you use that data is very important, and it has to be predefined ahead of time how the data will be utilized. When you employ technology that makes the data use safe and secure, that is definitely a very important part of conducting ethical research.
And of course, for the prospective data as well, there, and particularly for IoT or other devices, some of that will be collected outside the clinical boundaries as well. So if we have ways to ensure that the collection of that is also secured, we keeping that chain of security, but also verifiability, right? Because one of the things that confidential computing provides is the capability to prove that what you're looking at is the data you thought you're looking at and has been derived from models and data you look at. Because you wouldn't want, you talked about these new variables that an AI might come up with, but if the data has been looked at by an AI which is not the correct one or has been mistrained, that could be disastrous in terms of what we're using. So that verifiability of the data and of the application is, I guess, going to be core as well as we move in, particularly into future sort of treatment scenarios or deriving new possible approaches.
Sure, I wouldn't be able to say much about outside of clinical trial settings of data collection, but in general, I am excited, and I believe that technology will increase the level of what we know.
And we've talked a lot about the upsides. What concerns do you have about AI in the medical world? Particularly, I mean, both on the practitioner side, but also on the research side, where you're kind of bridging the gap. I know, but where do you what concerns, what dangers do you think, what challenges?
So I think it was 1997, if I'm not mistaken. Gary Kasparov lost to Deep Blue, to the computer. So I think he won in 1996, and then in
Hmm.
97 it was the first time that he lost. And from then on, uh, it's not a question anymore. And the world number one, Magnus Carlsen, when he's asked if he can beat a computer, he says, "No, what are you talking about?" So computer has been smarter than human in some sense for a long time now, and giving computer too much power or autonomy can be probably dangerous or scary, right? So AI, although I said earlier, and I still, of course, believe that it's going to be the future of medicine and all other fields, it needs to be regulated. It needs to be closely monitored. We need to make sure that the data that we use is used ethically and correctly and privately, and with the permission of the patients, to the extent that they give permission to, and no beyond. But I think all that is doable.
So, George, you mentioned just a while ago about a paper that you're working on. I guess that it's not published yet. Could you maybe tell us a bit about that?
Sure. So we don't know when it's going to be published. Depends on the reviewer. Well, depends when we finalize it. We're currently working on the results. To tell in brief, there was a study conducted here by a brilliant neuro-oncologist who used MRI spectroscopy data of the patients who had a brain tumor. So basically, values of their proteins in their brain that were read through MRI scans. And these patients had the tumors removed. And what they did is they trained an AI program. They wrote an AI program that had capability, that developed capability by looking at these protein values to predict where the tumor would regrow and if it would regrow at all. And I saw that the AI's results actually matched with what really happened. So what we did is we thought, what if we were to train this AI but didn't have this patient data, didn't have this MRIs? So we reproduced the same study using the confidential computing technology provided by Super, where we disseminated data to one department and the AI to another department, so that these two departments had no access to each other's counterpart intellectual property. And with use of the technology, we trained the AI without ever having to receive the data, look into the data, or have any access to it. We're currently working on the new trained AI to give us the same results, to give us results which we're going to compare to the published results of that study and see and give an example how in medical field you can train an AI without having zero access to the data.
That's fantastic. I love that. And looking at how you can reproduce data in different ways under different conditions whilst maintaining that confidentiality is fascinating. Excellent. Well, I would say I'd look forward to reading it, but I have a horrible feeling it's going to be beyond my understanding. But hopefully, I'll at least understand the abstract. So
No, we'll make it as simple as possible for everyone. The idea will be to demonstrate that this is doable. And the reason we chose to reproduce a study and not create a new AI that would do something useful
yeah,
in addition to already existing is so that we can prove that you can use this technology, have no access to data at all, train machine learning, and it will be exactly the same as if you did it on one computer.
yeah, that's hugely important. I absolutely agree. I see exactly why you've done it. I'll trust you that that'll be understandable to me and other lay people. That's great. I look forward to it. So, George, there's one danger when doing these sorts of recordings, particularly with the rise of lots of processing power and deep fakes, and that is that you might be an AI yourself. I'm absolutely convinced that I'm not an AI, and so what I'm going to do is I'm going to set you a little task, okay? And the task is I'm going to give you let's say 60 seconds to explain a topic of my choosing in a way which will hopefully convince me that you are not an AI. Okay? And so the topic is this, and I'll explain why afterwards, why I chose it. And the topic is, explain to me how many legs a dog has.
So I explained to you how many legs dog has by in a way that proves that I'm a human. I'm not an AI, right?
That's right. Yep.
I think the dog has that has 4 legs, but I also think that that's too easy of a question, and I didn't really like it.
Oh, that sounds right. Somewhat a human thing to say. Not liking questions. Maybe I could train an AI to say that I didn't like it. What would have been a better question then?
Well, I don't know what would be a better question, but I think if you train an AI to like things and dislike things, then it might become a little bit dangerous to use the AI, right? If it starts having its own consciousness and its own emotions and is significantly smarter than us, then God knows what it's going to decide to do.
Well, I've given you 60 seconds. I'm pretty much convinced, I think, George, that you're probably human. So the reason I chose this question is because when my younger daughter was quite small, when she was, I don't know, 3 or 4, I said to her, once, how many legs does a dog have? And she looked and she thought and said, let me go and check. And she went and found our dog and counted the number of legs and told me she'd had 4, which tells me that she's a very empirical thinker, which I kind of like.
A young
But that's kind of,
scientist.
yeah, well, sadly, she's not what she specialized in, but that's all fine. She's got the right thinking there. Anyway, thanks very much, George. I will, let's say for now that you're a human, and we'll take it from there. Thank you. And what have we missed? What have we not talked about today that you think we should have? Where have I messed up and failed to ask the right question? Because this is always the problem, right? When I'm interviewing an expert who is in a field that I don't know enough about, it's always a danger that I'm just going to miss the really important, really interesting question. So what should I have asked that you would have given me a great answer to? And tell me what the answer would be, please, obviously.
I don't think you missed anything. I think what would be great to address, and what is of a high importance, is what are the ways, and maybe I should have asked you this, what are the ways for us to investigate what would increase the assurance of scientific community that such technology is and can be of benefit.
Okay, to the various fields in which it could be used. I think that's a great question to be asking other guests, honestly. What are they, the people who are sort of firmly in the field of computer science and security, how can we help people who are outside or peripherally involved to have those assurances, and to look at not just the technological and the legal, but the ethical issues that you've also raised, which I have to say I've really enjoyed. So, George, thank you so much for your time. It's been lots of fun. I hope you'll get back to us if you've got some interesting things that come out. I'd love to find out how things go for you. But for now, thank you very much indeed for your time. It's been a real pleasure. Thank you.
Thanks so much. Thank you for having me.